So tēnā tātou katoa te lawhalava malo e lelei. Warm Pacific greetings. I'm Warren Elwin, Chief Executive of Work Counts, and on behalf of the Work Counts team, thank you for taking the time to join us today. Welcome. Whether you're tuning in from New Zealand or Australia or somewhere else around the world, we're thrilled to have you here. I'm also thrilled to be hosting this webinar covering the New Zealand Medical Journal's recent publication of the impact of IPS employment support on employment, health and social outcomes evidence from Aotearoa. The lead researcher, Moira, who was a senior analyst with Insight's Ministry of Social Development when the study was undertaken, will be presenting findings. But first, I'd like to begin by asking Riwiri, Tau Māori lead for Work Counts, to start this session with karakia. Thanks.
Tēnā koe, Warren. Tēnā te mea tika tātou katoa, māku te karakia, he whakarite tātou mō tēnei wahanga, nō reira kia inoe tātou. Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mākina kina ki uta, kia mātaratara ki tai. E hi ake ana te atakura, he tio, he hoka, he hauhu, tihei mauri ora. Tihei mauri ora ki te whai au ki te ao marama. Timata ngā kōrero ka tuku atu o mātou whakamuimeti, whakawheta atu ki te atua kaharawa. Nau te timatanga o te whakaaro nui, te whakamutunga o ngā mea katoa. Nau te kororia, nau te kororia, nau te kororia. Kia tau iho tāna korowai atawhai ki runga i te ariki nui kuini ngā waihono i te pō. Te hika hika matua o te whenua, te hika hika matua o te whare tapu o pōtatau te wherowhero. Te piki tūranga o tōna matua, ara e ai ki ngā kōrero, ko tu heitia ki te rangi ko ngā waihono i te pō ki te whenua. Tai noa ki te whare kāhui ariki nui tonu, pai māriri. Tangi atu te ngākau, heke iho ngā roimata ki ngā mate huhua o te wā nei. Rātau mā kua wheturangitia ki te pō uriuri ki te pō tangotango. Ki atu rā ki te kāinga tūturu a Hawaii ki nui, a Hawaii ki roa, a Hawaii ki pāmamao, no reira, haere, haere, whakangaro atu rā koutou. Hoki ora mai tātou katoa ki te ao marama. Ngā kano ihora o tō mātou nei tupuna, i hikoe ana ki runga i te mata o te whenua. Mauri ora kia tātou katoa, nau mai, whakatau mai rā. Ara, ko te kupu whakamutunga, toitu te oranga, toitu te wairua, toitu te kaupapa o te wiki o te reo Māori, he reo ake, ake, ake. Ka re kumeroa aku kōreroa, huri noa, tēnā koutou, tēnā rā koutou katoa. Kia koe, Warren.
Kia ora, Riwiri. Thank you for both clearing the way and adding to the welcome for our guests today. And it is this week here in New Zealand, Māori Language Week. So beautiful to have those words and energy washing over us at the beginning of the session. Righto. Work Counts helps organisations develop and deliver IPS employment support. And for us, we see these studies that are about to be presented on as historically significant. They are of interest not just for the opportunity to provide fundings and findings. That's an interesting slip of tongue, isn't it? But to provide findings and observations for the government's social investment approach here in New Zealand, but also internationally, we see the interest where IPS employment support is present. And Moira, to you now, I'm pleased again to welcome you. I want to take this opportunity, if I may, to acknowledge you for the commitment and rigour you bring to these studies, always values-led and data-driven. And you really do have a wonderful quality of both conducting rigorous research and being able to translate the findings well. So thank you for making time to be here today. And I think with that, it is now my pleasure to hand over to you.
Thank you, Warren, and tēnā koutou katoa. I'll just share my screen and then we can get started with the presentation. So thank you everyone for coming, and it's a real pleasure to be able to present this piece of work, which we've worked on over the last few years, it feels like, Helen, and it's a really wonderful thing to have it out in the world and to be able to share it. Sorry, my page down button is not working. Here we go. So acknowledgements and gratitude first to the wonderful study team who worked with us on this project: Fiona Cram, Cherie Gibb, Sarah Gray, Helen Lockett, Keith McLeod, who did all the hard work with the data, Debbie Peterson, all brought amazing contributions to the study. Also like to acknowledge Warren and Lisa from WorkWise. We couldn't have done this study without WorkWise's cooperation and willingness for us to be able to use their precious data. And also very grateful to Brian, Amanda and David from MSD who provided help along the way. So there's a rather large disclaimer that I need to present before we get underway. So we use data from the Stats New Zealand Integrated Data Infrastructure. That's a large linkage of administrative and survey data with national coverage. It's carefully curated by Stats New Zealand to give effect to security and confidentiality provisions of the Data and Statistics Act 2022. And it's important to emphasise that the results presented are the work of the author, not Stats New Zealand or individual data suppliers. The results aren't official statistics. There's more information about the IDA on the link in the presentation here. There's also a disclaimer about use of tax data. I don't think I say anything terribly critical about the tax data, but if I did, that's not a comment on Inland Revenue's use of those data for its core functions. And finally, our opinions and findings and recommendations and conclusions are those of the research team and are not necessarily shared by Stats New Zealand, MSD, or any of the other agencies that were involved in the research collaboration. So I'll take you through the background to the study and our aims, methods and limitations, talk through some results and our summary and discussion and conclusions. So most of you will be aware of what IPS is, but just in case, it's an internationally used evidence-based approach to employment support. And it's for people with severe mental health conditions or problematic substance use who are in contact with mental health and addiction services. It's an intensive program relative to some of the other employment supports that, for example, Ministry of Social Development funds. And importantly, it's voluntary. It's been available in parts of Aotearoa, New Zealand for 2 decades, initially funded by MSD, then by various health regions, and currently there's some funding from MSD and some funding from the health regions, but in spite of some recent expansion, it doesn't yet have national coverage. And when you get a copy of the presentation, there's a link to a map in the presentation. So our work on IPS, this current project started when 2 new trials of IPS were funded in the 2017 budget under the social investment budget stream. And a big emphasis of that budget funding was learning about effectiveness. So we received some evaluation funding, and that's funded this project and a whole lot of other pieces of work which are available at the link on this page. IPS has 8 practices and principles. A really key one is the integration of mental health and employment services. So there's co-location of mental employment specialists and clinical teams, and they work together to deliver IPS. The focus is on competitive employment, so not supported employment. Eligibility is based on client choice, so there's 0 exclusions. Everyone's invited and eligible to participate, regardless of their background or apparent job unreadiness. There's attention to client preferences, so the job search is consistent with the client's preferences and skills. Job search is rapid, so people are helped to look for jobs soon after entering the program rather than being, say, trained or put through various job preparation activities first, which is quite a contrast to other employment support. There's systematic job development where employment specialists, one of their tasks is to go out and actively build relationships with employment and proactively seek out the work opportunities for their clients based on people's work preferences. So they're not just responding to advertised vacancies. The job supports are individualised both to the employer and the employee, and their time unlimited. And finally, a key aspect is work incentives and planning to help people understand how working will affect their benefit payments and entitlements, and to ensure that those support people through the transition to work. So there's strong existing international evidence for the effectiveness of IPS from a large number of randomised controlled trials, and strong evidence that it has large positive effects on employment outcomes. So across 7 meta-analyses, rate ratios for employment ranged between 1.6 and 2.5 times more likely to be in competitive employment, usually with a follow-up of around 12 months, but sometimes longer. And there's a link to one of the very recent reviews on this page. The evidence base is still developing for other outcomes such as mental health and quality of life, and comparatively few studies have looked at flow-on effects on participants' total income, their health, their justice or education training and training outcomes, their welfare benefit use and other service use outcomes. So this was a gap that we were hoping to fill with the present study. There's emerging evidence that IPS can be effective for groups other than those with severe mental illness. So there are modified models being developed and trialled, for example, for people with PTSD, anxiety and depression, people with a history of involvement with the justice system, young people facing mental health and other difficulties in the transition to adulthood. And there's an interesting recent review of the evidence for young people that's available at the link on this page. So in 2020, we published a study together with Helen and some other collaborators looking at 5 case study DHBs where IPS had been operating for a fairly good period of time, which led us to look at outcomes being achieved using the linked data in the integrated data infrastructure. We found in that study that 1 in 10 of mental health and addiction service users in the teams that had an employment support worker attached to them accessed IPS over the 3-year window that we examined. And the participation rates for Māori and Pacific were not consistently higher or lower than average across DHBs. They did vary, but they were equivalent overall. And those who received IPS, when we looked at all their other characteristics and their employment background and their education and justice history, using the linked administrative data, we could see that they had high levels of labour market disadvantage. And we concluded from that that IPS was reaching, this intensive program was reaching people it was intended to support. We found that employment outcomes over a 12-month period, following up people from their date of entry into IPS, varied across ethnic groups in a manner that was consistent with differences in labour market disadvantage and labour market discrimination experienced by those groups. But despite that, for all the ethnic groups that we examined, employment rates were in line with or exceeded an ambitious international benchmark for employment outcomes from studies that have looked at IPS programs in routine settings, so outside of the RCTs. So the aims of this study, which builds on that initial study, are to estimate the causal effects of IPS participation on employment, health, education, and justice outcomes, and to look at impacts for Māori and by gender to improve the evidence base for future policy and funding decisions. We don't have an RCT for New Zealand, so our approach was a quasi-experimental one where we did the best that we could in the absence of a RCT to estimate effects. We used the linked administrative data in the Stats New Zealand integrated data infrastructure. We found people who participated in IPS in the 3 years to March 2018, I think that says, sorry, it's covered by my screen, in those 5 case study DHBs that we'd looked at previously. So those were Auckland, Counties Manukau, Taranaki, Waikato, Lakes DHB, and Taranaki, sorry. I'm going to need to move you all over a little so that I can see. Yes, I just put Taranaki twice handily. So it definitely included Taranaki. And all those DHBs had established IPS programs at the time. So we also limited that sample a little. We focused on people out of work in the months before their IPS participation started. And we did that to maximise policy relevance for MSD and to align with the overseas evidence base from RCTs. People who are in employment can participate in IPS, but we didn't include them in this study. We used propensity score matching and hard matching on selected characteristics to match with people who used mental health and addiction services in the same groups of DHBs and appeared similar but didn't participate in IPS. And then we compared the outcomes of those 2 matched groups over the following 3 years to estimate the impact of IPS participation. Just a bit more on the matching. We exact matched on the quarter and year. So if an IPS participant had started IPS in the first quarter of 2018, we looked for someone who had had a mental health and addiction team engagement face-to-face in that same quarter and year, and that was one of the matching criteria. We matched by whether the person was in the Auckland, one of the Auckland DHBs, by whether they were of Māori or Pacific ethnicity, and whether they were on a main benefit and the broad type of main benefit that they received, if so. We probabilistically matched on a wide range of other characteristics which could also affect both people, either people's selection into IPS or their outcomes over the 3-year window using estimated propensity scores. So I'll talk about a bit more about this in a minute. We used matching with replacement, so we could have the same person in the matched control group matching with one or more of the IPS participants in the sample. So the propensity score part of the matching took a whole lot of characteristics of people and modelled their likelihood of participating in IPS based on the observed relationship between these variables and the participants' participation. There's quite a lot of different measures in here: location, qualifications, sex and ethnicity, rural urban status, driver's licenses, their family status, whether they had children and the age of the youngest child, their labour market income and employment history, a whole range of measures of past engagement with mental health and addiction services and pharmaceutical prescribing, some measures of co-occurring health conditions based on the elixir method measures, past hospitalizations, and the intensity of past contact with mental health and addiction services. We also included the benefit type and the benefit history, whether people were recent migrants and the share of their life that they'd spent in New Zealand, whether they had a history of correction sentences, and their education and training history, as far as we could observe it in the administrative data. Another point here on how we assessed statistical significance. So we were examining a very large number of outcomes across multiple populations, and so some of the estimates of effects that we found could have been statistically significant by chance with that number of estimations going on. So we accounted for that by being a bit more conservative than you would usually be by using something called false discovery rate adjusted Q values when we assessed statistical significance. Before I get to the results, there are a few limitations that's good to acknowledge. We could check that these two groups compared well on characteristics that we could observe in the IDI, but we can't be sure that they didn't differ in unobserved ways that influenced both their likelihood of selecting into IPS, but are also important to their outcomes. You can think that that might go either way. For example, more disadvantaged people might be more likely to select into IPS and have more challenges in the labour market. So perhaps we're selecting on a group who have worse employment outcomes when we're doing the comparison, and so maybe the IPS participants have more challenges in unobserved ways than the matched group, or it could go the other way and you could have a more motivated group coming into the program, and we haven't been able to control for motivation, so that might be meaning that the IPS group have better employment outcomes for this unobserved reason, and would be expected to have more favourable outcomes. So we don't know which way that unobserved but potential for bias would go. We do apply a sensitivity test to try and assess how much that might be driving the results, and I'll come back to this when we're going through the results. Another limitation was that we couldn't find matched controls for all the participants, and again I'll come back to this later as I go through the discussion and results. Not all of the outcomes sought by IPS are able to be measured using the data that was available to us. In those data we could measure aspects of mental health, service usage and prescriptions and hospitalizations, but we couldn't directly measure mental health and quality of life. So that needs to be borne in mind, that we're measuring service use, not actual mental health. Measures of wellbeing from a Māori worldview were absent from our set of outcomes. We have small numbers in our main sample, and we're also trying to estimate effects for subsamples, and that means even smaller numbers, and that can make detecting statistically significant effects challenging. And the numbers don't yet support subgroup analysis for Pacific or other subgroups that are of policy interest. So with that, we can turn to the results. So in total, we found 1,839 IPS participants who received IPS in the 3-year window we were looking at and hadn't been in employment when they started IPS and were in the working age groups. Of those, we could find matches for 1,659, and the number of matched controls was 1,503, recalling that each control could match to more than one of the participants. The first thing we look at with a study like this is how well the matched participants and matched controls compare on observed characteristics. And in our case, they compared quite well, so very similar proportions in the different demographic groups, in different areas, in different ethnic groups, which is not unsurprising because we did a bit of hard matching there. What gets interesting is some of the service use. We didn't match on corrections history, but we have very similar proportions with sentences in the last year and offences. Some of these comparisons are speaking to the highly disadvantaged nature of the cohort that is being served by IPS. When we looked at health service use and prescriptions, high rates of being prescribed antipsychotic medication, similar proportions with different diagnoses in the data. Most had 4 or more crisis contacts with mental health services in the past 3 years. About a third had mental health related hospitalizations in the past 3 years, and about a third had non-mental health related hospitalizations. High use of emergency departments as well among the cohort, and around 8% with self-harm related hospitalizations. So that's the cohorts. Those are the cohorts that we're looking at. Another thing that we check before we look at the results is whether we have similar propensity score distributions for our matched participants and matched controls. So in this plot, the matched participants are the orange and the matched controls are the dark blues. And you can see that those distributions for those two groups in terms of the propensity score, which is measuring kind of how likely do we think you were to participate in this program given your characteristics, those distributions look quite similar for the two groups, which is what we want to see. What looks quite different is the propensity score distribution for the unmatched participants. So they have on average higher propensity scores. So it's really interesting that we're less able to match the group with the highest estimated propensity to participate. Just a bit more about that group that we couldn't match. They appeared to face more employment challenges on average. So we weren't able to find matches for 10% of participants. They were more likely to be male, to live in Auckland, to be Māori, Pacific or Asian, and to be receiving a job seeker health condition or disability benefit. They were much more likely than the matched participants to have been prescribed antipsychotic or antidepressant medication, to have a schizophrenia, bipolar disorder or substance use diagnosis recorded in the data, and to have had crisis contacts with mental health and addiction services or had past mental health and addiction hospitalizations. So this is quite a more challenged than average group. So we'll just park that group to the side for the moment and we'll come back to them towards the end. So this is the first set of results that we have where we're comparing the outcomes of the matched groups over the 3-year follow-up. So we looked at the matched IPS participants and the matched controls, and we counted up their months in employment over the 3 years. And within that, the months that they were employed while on a main benefit, the months they were employed while not on a main benefit, and the months that they were on a main benefit. So these are our sort of main benefits, refer to the payments that are sort of aiming to replace most of the person's income if they're unable to work. So in New Zealand, those are supported living payment often, or job seeker support for a person with a health condition or a disability, but it can also include our sole parent support payments and job seeker support, just the regular job seeker support. So for the sample as a whole, we saw the matched participants had more months in employment, and that was highly significant at the 1% level. They had more months employed while on a main benefit, and more months employed while not on a main benefit. Months on benefit were up, but that was not a statistically significant result. And for Māori, at a lower level of significance, we get the same patterning of results. Oopsie, sorry. And for males, we also get the same patterning of results, more significant for months employed and months employed while on main benefit. For females, we get more positive, we get significant results for months employed while not on main benefit, as well as for those other measures, and months on benefit were down for females. That result wasn't statistically significant though. Here's how that looks with time from participation start. So along the horizontal axis, we have time running from -12, which is 12 months before participation start, to +36, which is the 3 years after participation start. And at 0, you'll see everyone's not in employment, and that reflects our selection criteria for the sample. What we see in the period before participation start is what we want to see in a study like this, which is that the employment rates, the percent in employment at each period is very similar for the matched participants and the matched controls, and there's no statistically significant differences in their employment rates. After the participation start, we see an employment rate gap opening up between the two groups, which is at its largest at around about 12 months and gradually closes over the 3-year follow-up, not because the participant group is dropping out of employment or their employment rate is falling, but more because the matched controls are catching up. So by 36 months, the gap has closed, but it's still a statistically significant gap in employment. And this shows the percentage employed while on a main benefit. And again, we see similar patterns, similar rates of employment while on a main benefit in the 12 months before participation. After participation starts, we see this gap open up. It's largest in the first year after participation starts, and not statistically significant at the 36-month mark. Here's the proportion in employment while not on a main benefit. This seems to kind of open up a bit over the first year, and is the gap's at its largest in the second year after participation starts. and then again narrows. Well, both groups kind of level off. It moves in and out of statistical significance in that third year, but at the 36 mark, the difference is statistically significant. So turning now to the estimated impacts on income. So we found net income from all sources, so that's total income from employment, net of taxes and transfers, that was up for participants when compared with the matched controls, and net income from employment was up. Net income from MSD benefits was up, but that wasn't statistically significant. Net income from other transfers was down, again, not statistically significant. Taxes paid were up, but not statistically significant. And net government transfers, so benefits and transfers less taxes paid, were down, but again, not statistically significant. For Māori, the patterning of results was the same, but none of those results were statistically significant. For males, only the increase in income from all sources was statistically significant. For females, the pattern was quite different. So their net income from all sources was down, although not statistically significant. Net income from employment was up. Net income from MSD benefits was down, and as well as net income from other transfers. So that includes things like working for families, tax credits. Taxes paid were up. Again, those weren't statistically significant, but when we look at net government transfers, so benefits and transfers less taxes paid, they were down, and that was statistically significant. So that's probably explaining the negative effect on net income from all sources, which, although not statistically significant, we're seeing. Turning now to what we saw for correction sentences. We looked at months serving any correction sentence, so those include non-custodial sentences. Those were down, but not statistically significant. And we also looked at months serving that should just say a custodial sentence, and that was down, but not statistically significant. The results were down for all our subgroups, but not statistically significant for any. We'd really love to update this study with a larger sample when we didn't use the false discovery rate adjusted Q values. The result for males was statistically significant, which suggests that with a larger sample, we may see some statistically significant results there. We looked at impacts on study and qualifications. Months enrolled in study were up. The proportion gaining a qualification was up, and the proportion gaining a qualification at least level 2 on the National Qualifications Framework was up, and that was statistically significant. And we don't see any other statistically significant effects there. And in general, the pattern is the same, although for males, it looks like months enrolled was down, but not statistically significant. We looked at a range of measures of health service use over the 3-year follow-up. So we looked at months with IPS face-to-face contact, as would be expected. That was up for the IPS participants when compared with the matched controls. What was also up was the months that they had mental health and addiction team face-to-face contacts. So those were also up. The proportion with a mental health and addiction inpatient stay in the 3-year follow-up was up. The proportion with a mental health and addiction crisis contact was up, and all those results were statistically significant. Not statistically significant was an increase in the proportion with a hospital admission for self-harm, and a reduction in the proportion with a non-mental health and addiction inpatient stay, and an increase in the proportion with emergency department visits. The patterning for Māori and significance was quite similar. Similarly for men, some significance. For women, the reduction in non-mental health and addiction inpatient stays was statistically significant. So just looking at the time pattern to the face-to-face contacts with an IPS team, as we might expect, most of the contact with the IPS team happens in the first year, and it's most concentrated in the first 6 months following participation. But you can see with the time unlimited supports, there are some people still receiving supports out at 36 months following the participation start. It's an interesting story to be able to tell. And the proportion with mental health and addiction team contacts, again, the difference between the matched participants and the matched controls is biggest in that first year, but remains out to the end of the follow-up. And again, reassuringly for our method, we see the groups with very similar levels of contact in the pre-participation period. So just to give you a sense of the scale of the statistically significant impacts that we found for the total matched sample, the IPS participants were 1.6 times more likely to be in employment at 12 months and 1.3 times more likely to be in employment at 24 and 36 months after they started participation. They were all spent in total almost 3 months more employed over the 3-year follow-up. They had 4,221 more income from all sources than the matched controls in 2018 dollars. They had $5,056 more employment income over that 3-year window. They were twice as likely to gain a qualification at the NQF level 2 or above, and they spent 4 more months with mental health and addiction face-to-face contacts in that 3-year window. They were 1.3 times more likely to have a mental health and addiction inpatient stay, and 1.3 times more likely to have a mental health and addiction service crisis contact. So the sensitivity testing that we did was to match with people in contact with mental health and addiction services in DHBs that didn't offer IPS during the study period. So that was useful to examine because it reduced the potential for any selection bias in participation, because we knew that the matched controls were not being offered the program. But the matched controls would have experienced quite different labour market conditions and mental health and addiction and other service configurations. So we might have still expected there to be some reasons why you would expect their outcomes to be different. Despite all of that, the results in terms of what we're estimating for effects on the various outcomes were very similar. So to summarise and discuss the findings, we found positive effects on employment income, employment duration, the rate of employment, which reduced over time as the employment in the control group increased. That's consistent with the international evidence from randomised controlled trials, and it's useful to know that that's what we see in Aotearoa, New Zealand, when we apply the closest we can get to a randomized controlled trial. There were positive effects on income and qualifications. The matched participants had higher total income after accounting for any losses of benefits and other transfers and taxes paid, and they gained more qualifications. So that's a bit of a contribution to the evidence base. There's relatively few previous studies that have examined effects on those outcomes. There was no increase in total income for females, however, and that's a really important finding to spend a bit of time thinking about. So their increase in employment income was offset by decreased benefit and other transfer income. And we think this suggests a need to strengthen benefit counselling and improve possibly the design and delivery of income support through work and income, or strengthen connections with inland revenue. It's interesting that we found this effect for women, and we hypothesised that they were more likely to be mothers and have more to lose by not knowing about their in-work benefits that they could receive. So women tend to be the person who receives family tax credits. A lot of the women accessing the program were receiving sole parent benefits, and just being able to know about the childcare support that's available through the benefit system, that you can continue to receive accommodation supplement when you're in work and off a main benefit, and that you are able to access family tax credits through inland revenue when you're off a main benefit, are all very important to being able to sort of put together a package of income that ensures that income is better when people are off benefit rather than on benefit. Certainly the policy settings are designed to ensure that people are better off in work, but that requires take-up of payments. The increase in mental health service usage that we see does provide a bit of a puzzle for interpretation. It could reflect beneficial effects where IPS was increasing engagement with mental health and addiction treatment and care in the transition to employment, resulting in people being more readily able to access needed services, and or clinicians engaging more proactively with IPS participants. So perhaps that's the story behind why we see more crisis contacts and more inpatient stays, is that people are getting services when they need it because they are having frequent contact with the IPS employment support specialist, and that's helping them access the clinical services they need. But we know that employment can be stressful, and we might also be seeing negative effects on mental health from the process of being unemployed and actively seeking work and moving into employment. To the extent that those are there, we sort of think this speaks to the rationale for IPS, where the whole point is to acknowledge that this is a difficult and stressful transition for people, and the integration of employment and mental health services is designed to mitigate these very effects. So in some ways it's not surprising that we see them, but it is an area where we would like to learn more about what's going on there. When we look at the international evidence on effects on mental health and well-being, there's not a lot there. There's a meta-analysis of the few studies with results for quality of life, global functioning and mental health, and those suggest positive effects, but with confidence intervals that are including the null, and quite a lot of heterogeneity between the studies. We were interested to find one RCT which reported outcomes like our study. So it found that IPS participants had more contact with mental health services and more use of emergency care and psychiatric evaluation than the control group. but when they did direct measures of psychiatric symptoms and self-reported quality of life, there were no substantive effects. So that was an interesting study to reflect on. Another contribution that we make to the literature with this study is to look at efficacy and effectiveness, or to look at effectiveness for Indigenous peoples. So while our results suggest that IPS provides effective employment support for Māori, we do think that further research is needed to identify and support the strengthening of the cultural principles underpinning implementation for Māori. We also note that we can't compare results for IPS with programs for which impact evaluation evidence is sparse. So there's a range of kaupapa Māori employment initiatives, and it will be important that they have their research and evaluation resources to develop and build their evidence base as they develop and grow. And only once we're able to see those programs effects will we be able to put these results side by side with those. And just returning to that question of the unmatched group, there's a question of whether our results for the matched groups is over or understating effects across all participants. So had we been able to include those people who we couldn't find matches for in the study, would we have found greater effects, or would we have found more modest effects? We don't really get much good guidance on this from the existing evidence base. So if there's a meta-analysis of results for different subgroups from RCTs, and it shows that IPS is effective in increasing employment irrespective of diagnostic, clinical, functional, and personal characteristics. So there's no suggestion that, for example, people with people in different ethnic groups or different age groups would be more or less likely to benefit. It is more effective for populations with serious mental illness than for those with common mental health disorders. And you recall that we seem to have a higher proportion with schizophrenia in the unmatched group. But it's also more effective for those with low symptom severity at baseline than those with high symptom severity independent of diagnosis. And we did have a lot of more frequent mental health service usage in the history of the unmatched group, which might suggest that we had higher symptom severity in the unmatched group. So we think on balance, we can't really say whether we're overstating or understating effects by looking at a group that excludes this unmatched group. So in terms of our conclusions, we think our study demonstrates the benefits of IPS in supporting employment and improving income and qualification for people in contact with Aotearoa New Zealand mental health and addiction services. And combined with international evidence, this suggests that expanded IPS availability would be beneficial to fill those gaps in coverage that still exist around the country. We do see the opportunity and need for more research to understand the effects of IPS on mental health symptoms and broader wellbeing, to support cultural responsiveness for Māori, and to repeat this impact evaluation with a larger sample in coming years to understand more about effects for a broader range of subgroups, and, for example, to have another look at those effects on justice system rehabilitation. So thank you. I'll stop sharing my screen and hand back for discussion.
Thank you, Moira. That was great to go through all of that. We do have a bit of time for Q&A now, and Helen will lead us through that. If people have got any burning questions they want to ask. We have Tyrone, who's General Manager of Workwise, the provider that was largely involved in this study. Dr. Helen Lockett will be known to many of you, and of course Moira. So Helen, I'll hand over to you.
Kia ora koutou, and ngā mihi nui, Moira. Beautiful presentation as always, giving us a whole clarity in terms of the way the research has been conducted. We've got a few questions come in. One is access to the journal article. So my suggestion would be to email Moira or myself for access to the New Zealand Medical Journal article. And we'll put the link up as well for those of you who can access it. But there's a couple of research questions come in, Moira. The first one is how did we track participants out to 36 months after commencement? Is this due to the participants still connected with the DHBs?
The great thing about the linked administrative data that we were able to use was that it didn't rely on the participants being still connected to the DHBs. We could link up with their tax data to look at their earnings, with their hospitalisation data, to look at mental health service usage and education data, all based on whether they had started the program. So we didn't rely on remaining in contact with them to observe their outcomes. The linked administrative data let us observe their outcomes long after they had potentially left contact with the service.
No, thanks, Moira. And the second one is also about a research question, which is, are there any plans to conduct a randomised controlled trial in Aotearoa? I can answer a bit of that to say, not that I'm aware of at the moment, but I also think, what this study demonstrates is how the value that you can get from linked data compared to the money it would cost to run a randomised controlled trial. But also now we have an understanding of the effectiveness here. Then actually there are ethical complications in terms of running a randomised controlled trial by saying, well, we know this is more effective, but you can't have it and you can, in terms of that. But the question is, I don't know if you know anything, Moira, are there any other plans to?
Not that I know.
And I think for me, the priorities of research are as Moira outlined within that final slide. We really want to understand more with a larger sample. So we could repeat this. So we're showing the utility, and this is a very cost-effective way to conduct very thorough, rigorous research that mirrors the conditions of an RCT, but doesn't cost the same. Any other questions? Do keep them coming in.
Helen, there's one in the chat.
Yep, I can just see that. So the questions coming in from Louisa, thank you. I have any of the study participants identified as being refugee background?
I'm sorry, we didn't look at that in specific. We did look at migrant background, but not refugee background. But yes, and with the small numbers, that would be getting down to a subgroup that it would be very ambitious for us to look at with a small program and small numbers who are then from a refugee background, but a really interesting and worthwhile question.
And the other part of the question is about the different types of jobs, whether people stayed in the same job. Again, we weren't able to see that level of detail, I don't believe, were we, Moira?
It would be possible in the data to count the number of different employers a person had over that period, but that's not something that we did.
We have Suzanne congratulates us on the study, about to conduct an economic analysis and social return on investment on IPS in the Australian context. We also don't have strong national coverage despite positive outcomes. What are your plans, policy briefs, recommendations, refunding for IPS based on your research? Don't know if you want to answer that, Moira, or hand over to Warren to answer that one.
Yeah, so I'm no longer with the Ministry of Social Development, so I can't speak to Ministry of Social Development's intentions, but Warren does.
Yes, so whenever I'm happy to step in there as best I can, whenever government data organisations like Insights, the Ministry of Social Development, our welfare ministry, publish research of this scale and scope, it it is submitted and presented to policy teams. So no doubt Moira's done a swag of presenting to various ministry policy teams, whether that's in health or welfare or I'm not sure how many you did, Moira, but Treasury, others, and a number of those ministries did raise this research to their chief execs, and at least two of the ministries, including the Ministry of Social Development, raised it to their minister, and so it has got out there and garnered quite a lot of traction and notice. And I think it's because of that uniqueness of utilising all of that administrative data from education, health, tax, etc., to see what the impact of IPS employment support has been.
And I think in terms of your question around what else we're doing, one of the points of the webinar is to put the information in the people's hands, really, so that you can champion wherever you are in your role. I think particularly, from a lived experience perspective, if I'm looking for work, then this evidence is saying, look, if I've got better chance of getting employment and earning more if I have access to an IPS support service. That's what this study shows. I know we've got a number of policymakers in the audience today. Again, hopefully you've got this information and you can speak to it now, in the circles in which you're working. So I think that is a really important part of this, is getting this information to people to bring change.
Thanks, Helen. I mean, one of the interesting, you speak to it in the presentation, Moira, was about people's accessing mental health services went up. And, that's an interesting finding for people. Tai, from a provider's point of view, would you have commentary on that?
Yeah, kia ora koutou, everyone. I think it is really interesting, and there's and I know there's been several pieces of research across employment and even housing which shows an increase in engagement with health and welfare supports or other support. Some of that is because people are much more proactive in themselves about engaging. Some of it is, of course, with that wraparound support and just acknowledging all of the employment consultants and all of the clinicians that work in this space, that integration means that sometimes people's warning signs or triggers, or even just their communication with people, increases. So we actually see sometimes more proactive inputs and responses. The employment consultants talking to the clinician, the person being supported may flag something that then comes up in a multidisciplinary team meeting. We see trust increase around service because, of course, it's very recovery focused. And we've even heard, and this is a little bit anecdotally at times, clinicians coming back and saying, well, I haven't heard from this person for a while, but now they're doing some employment work. They're calling me up and saying they've got some interviews or this is happening. So we actually see engagement increase and people being proactive and coming before they're in crisis, or when they're in crisis going, actually, I need some support because I want to get back to my job or I want to continue on this journey. So I suppose it's not a negative, it's a positive when engagement increases, because actually people are being more proactive than being disengaging, and then that becoming worse. And it's probably an area I could talk about forever, but I'm also conscious we've only got a few more minutes left on the meeting.
Great. Thanks, Tai.
There's another question come through. I was also just thinking about additional question around the funding. I mean, there's no doubt that here we do need to look, like other countries have, at an integrated funding structure between initially, say, health and MSD, but we've also got ACC so that we can increase access. So there was a question about that in the chat, and I think we're in a great opportunity to do that now. Another question is, does the published article include qualitative-based stories of the participants? Often these can add value to seeing the impact on a person and their whānau.
No, but some of the earlier research that we did have some case study research, and there's a useful review of qualitative research that was done by the Centre for Person-Centred Research Helen, you'll be able to correct me at AUT, that has a useful roundup. But no, that wasn't part of what we did. But you're right, it would be a really useful thing to be able to complement the study with more work on clients' experience, and that would be another useful lens to understand our findings around mental health service usage.
Great. Look, thank you, Helen, for going through that. Questions that we haven't quite got to, we will answer those as best we can in writing and send those out to you, all those that have registered here today. And as well as that, the recording will be also sent out to you. Look, I'm aware of time, so we need to bring the session to a close. Thanks again, Moira, for presenting. This is complex research, and I congratulate you and the team, both for the publication, no mean thing to get into the New Zealand Medical Journal, but the work is really useful. It helps a great deal to inform the future. And look, a big thank you also to the webinar team for your time and expertise, and to all of you present for joining us. We know your time is valuable and we appreciate you spending it with us today. If you've got further questions or you'd like to continue the conversation, please don't hesitate to reach out to us. If you want to stay in touch with the latest evidence in relation to employment support, please sign up to our e-newsletter, Work Counts website. Also information on the Asia Pacific IPS learning community available. Again, that link on the Work Counts website. Work Counts also provides a whole range of training to implement employment support practices. Those training programs are available there. And once we close off this webinar, you will receive an email with a link to a really short survey so we can gather feedback to sort of inform future events. And please take the time to complete it, and there is a connection to the Work Counts website there for the links. So with that, everyone go well into the rest of the day, and I'll now hand over to Riwari to close with karakia.
Ka whai. Kia ora tātou, nē ranga mea tuki a tātou katoa, mā ku te karakia he whakakapi i tātou tēnei wā, nō reira, kia ino e tātou. Kia taunga manaakitanga mai te runga rawa ki runga ki a tātou, kia māhia te hua mā kihikihi, kia toi te kupu, toi te mana me te oranga o tātou katoa. Kia wātea te urutapu nui te ngākau te tinana te wairua o tātou katoa. Kia wātea, aira, kua wātea. Turuturu o whiti whakamaua kia tīna, haumi e, hui e, tai ki e. Tēnā koutou.
Kia ora. Go well, everyone.